this is Mark Kwan. Once again, welcome to the third episode of The Road to Antalya. In this episode, we have two guest contestants from the Middle East region. The first presenter is Dr. Nawal Al-Mutawa from Bahrain. She's a highly decorated clinician and an educator. She also has a PhD in science and philosophy of dentistry. And we can clearly see her multidisciplinary approach to her clinical cases in the presentation. Her delivery of the presentation was clear and was easy for the audience to follow. The presentation was well scripted and reflected in her excellent time management. The use of photos and illustrative materials were appropriate. Dr. Al-Mutawa is a well-rounded clinician who embodies the essence of lifelong learning. We wish her good luck in the upcoming Continental League. The title is Implant and Alignment, Multidisciplinary Approach for Restoring Missing Teeth. Please enjoy.
So this is a very short introduction about myself. My first degree was in prosthodontics, and then I studied implantology in Germany. Then I studied also orthodontics. So I do multidisciplinary treatment in my office. And I'm a member of the International Association of Orthodontics and Implantology. So my topic today is about implant and alignment, a multidisciplinary approach for restoring missing teeth. My agenda is, first of all, I will do some short introduction about my topic. Then I will discuss two clinical cases and show my references, and lastly, the take-home message. The introduction: when the patient comes to the office, so he has a chief complaint, but we do our clinical examination, which include the intraoral and extraoral examination. And also we take the initial records, including the intraoral photos, extraoral photos, x-rays, scans, different types of records. And then from these, we extract the diagnosis, our diagnosis as professional practitioners, and the problem list. And we discuss with the patient the treatment options available for him and what suits him according to his age, compromised conditions, or economical factors. And then we go to the treatment plan. So I always follow this SMART rule for the treatment plan. I try to be specific to what the patient needs, what he really needs, and according to his chief complaint and my diagnosis, measurable. I can measure how much I'm going to improve the case by millimeter or by size or whatever, or by aesthetics. Achievable. Can I achieve that result? Realistic. I don't want to be idealistic. I want to be realistic. And timely. That time is very important. How long it's going to take to achieve the goals. So this is case one. I will show you here Muhammad. He is 31 years old. He came to me, wants to replace a missing upper right six, but he also complains of hidden lower teeth and gummy smile. So when we take a brief intraoral photos that shows the main or the major problems that we can see: the gum smile, he has a deep bite, hidden lower teeth, median diastema, and lack of space for the implant for the upper right six. And the initial records we can see on the right side. This is a small space. We cannot restore it with implant. And also the bridge will be very aggressive for the patient. And you can see the gummy smile in the upper and the lower arches. The initial x-rays, it shows also our problem. And the treatment plan. I want to correct his deep bite, which is his concern. I will enhance his smile and open space for the future implant. My strategy correction of the deep bite will include the intrusion of upper and lower teeth. I want to flatten curve of SP, and I will open the space by distalization of upper right 7 and upper right 8. How can we do that? I will do that with clear aligners in 34 weeks. And you can see here that I will move the 8 first, then the 7, and the space will open. Meanwhile, the bite is opening and curve of SP is flattening. So we can see here the progress step by step. Initially at week 4 and then week 8, week 16, the space is starting to open, and finally we have our space for the implant. And we corrected his deep bite. So here are the final photos of intraorally, right side, left side, and front, and upper and lower occlusal photos. And if we compare initial to the final, after alignment, that we achieved our goals for opening the space and correcting the deep bite. And we can see the comparison in the smile, a big difference in the smile. So, and here, after initially and after restoring with the crown, and you can see the crown also from the occlusal. And the X-ray, we have the X-ray initially, after opening the space, and after implant insertion. And here, 1 year follow-up, we can see good integration and maintaining the results. And happy patient, happy dentist. So case 2, I will introduce Afaf. She's 37 years old. Her main concern also replacing missing upper left 5, but also she is not happy about her smile. She has generalized spacing in the upper and the lower teeth because of the missing tooth. And again, the diagnosis and the problem list that we have flared teeth, space, and lack of space for the future implant. So these are the initial. We have good occlusion at both sides and just the generalized spaces anteriorly. And here the initial X-ray and treatment plan. I will close all the anterior spaces, enhance the smile, and improve the space for the implant at upper left 5. So my strategy, I will retract upper and lower anteriors, and I will maintain the posteriors in position because they were in good occlusion, and I will use them for anchorage. So here, lateral view of the treatment plan, that just retraction of the upper and the lower with some intrusion, and you can see that I blocked the posteriors. And only in 14 weeks, we got this result. Enhanced the smile in a very conservative way, and we replaced the missing upper left 5 with a crown over implant. And here the final X-ray with the implant. If we compare initially and finally, and in this case that I start to insert the implant from the first month of treatment because there was enough space to have my implant, and then only I expanded with 1 millimeter. So in 5 months total treatment that this case was finished. And we can compare the X-ray initially and finally with the implant. So my references is the bone which is generated after orthodontic treatment is strong enough to hold an implant? Yes. And these are my references from these two respected journals. And my take-home message, first of all, we have to consider the chief complaint of the patient and we get the detailed diagnosis. We have to get good initial progress and final records, and we keep a close monitoring of the progress. And of course, we continue learn and keep educated. Here, going back to the history, in 2001, where I started learning implants from Dr. Hans Graffelman in Bremen and Dr. Manfred Lang from 2001 to 2003. I spent in Germany and learned from both legends. And this is my message, personal message, that knowledge is a message, and it shouldn't stop by us. And thank you. This is my social media. If anybody has any question, he can contact me through these channels. Thank you.
The next presenter is from Lebanon. Dr. Bakar Husseini, he is an oral surgeon and implantologist. First graduated from the St. Joseph University of Beirut as a dentist, and then earned his master's degree in 2020. Additionally, he earned a university diploma in oral pathology in 2019. He excels both as a clinician and in academia. He has published many articles in peer-reviewed journals concerning oral implantology, oral surgery, and oral pathology. And it is obvious that his expertise and passion on these subject matters throughout his presentation. The use of xenograft is nothing new in the field of bone grafting. However, like all things in life, nothing is perfect. In this presentation, Dr. Husseini gives us an insight on the pros and cons of xenografts and how the use of hyaluronic acid can help to overcome the limitation of this useful graft material. The title of this presentation is Bioactivation of Xenografts Using Cross-Linked Hyaluronic Acid, a Socket Preservation Case. Please enjoy.
Today, I will be sharing with you a case of socket preservation with a twist, let's say the bioactivation of xenografts. First of all, I would like to introduce myself. My name is Dr. Bashar Husseini. I'm an oral surgeon, member of the French Society of Oral Surgery and the American Academy of Implant Dentistry. So, we are living longer, it's a fact. The average life expectancy is 75 years. It goes without saying that the quality of life has been increased in the recent years. And as for the dental concern, there is almost 3 million dental extractions performed in 1 year, and this study was in UK. Such fact will leave us in a world full of extraction sockets and unlimited possibilities. We can go through immediate implantation, delayed grafting, socket preservation, and others. So, according to the study that has included 23 articles, 10 prospective studies, and more, and a huge number of implants, dental implants, the survival rate with cumulative mean values is 94.6%, which leads us to the fact that the number one treatment for missing teeth are and will be the dental implants. But before tackling dental implants, there is something that we have to consider. It's the bone and soft tissue alteration in extraction sites. According to a study by Chapuis, Vivian et al., we can have a 50% of ridge width reduction during the first year, and 2/3 of those 50% can take place within the first 3 months, which lead us to some place where we can't place our implants. That's why we go to grafting and the delayed approach, of course. Currently in the market, there is plenty and a lot of bone grafts. It can be xenograft, alloplastic graft, allografts, all of them. They should be biocompatible, promotes bone healing, ease of use and access, and affordable price. So today I will be talking about the xenografts. Xenografts have shown excellent results since they are only osteoconductive. Um, they act like a scaffold only, but they have their drawback, such as we can see here. Where is it? We have the worst bone formation at the 5 months, according when comparing to allografts and control. They have the highest residual graft particles at the xenografts, of course, which leave us in a good healing but delayed healing, let's say. So, in order to solve this problem, clinicians are thinking out of the box. They are considering the addition of biological adjuvants such as PRF, endogain, growth factors, and others in order to promote and boost the healing. In my opinion, boosting the healing is something really crucial for the benefits of the patient and the oral surgeon dentist. So today I will be talking about the hyaluronic acid. It was discovered by Professor Carl Mayer, first isolated from bullseye. It's a major component of the extracellular matrix, which means it's a natural component of our body. Chemically, it's a polymer of non-sulfated glycosaminoglycan and can attract times 1,000 of its weight in terms of H2O molecules. It's currently used in different medical fields such as ENT, urology, surgery and wounds, dermatology, cosmetics, and others. However, before using it during our surgeries, one must know how it works in the biological terms. That's why I made this table. It's a little bit complicated, but as you can see, it interferes with each phase of wound healing. To make things more simple, I made this one. As we can see, in the four phases of wound healing, hyaluronic acid can interfere, such as hemostasis, inflammation, proliferation, and remodeling. So we have two types of hyaluronic acid. The native hyaluronic acids that has a bioavailability of 2 weeks, and the cross-linked, chemically modified, which means that has a bioavailability of 6 to 8 weeks. In my opinion, we have to use the cross-linked in bone healing, not soft healing, not soft tissue healing, since the bone healing process takes approximately 5 to 6 months. 2 weeks is not sufficient. There are billions of studies, a lot, not billions, of course, but a lot of studies that has tested the efficacy of hyaluronic acid on bone healing, but the majority of them are in vitro. That's why I will show you today a clinical case of socket preservation. I showed the most simple case, that is a socket preservation, that any dentist can be doing it for a reason. The less is more in implant dentistry. The patient must be comfortable, less pain, and less time, instead of doing guided bone regeneration. We don't have to be heroes to solve problems if it can be solved in a simple way. So, as I said before, the best way to regenerate is to preserve. Let's talk about the patient. She's a female, aged 34, ASA 1, no medication intake, absence of pathologies, non-smoking, good compliance, preferred implant therapy over conventional prosthodontic bridge, but has a low budget for an immediate implantation. Clinically, she had a thin gingival phenotype, badly decayed teeth number 13 and 22, presence of papillas, absence of pockets around teeth, and acceptable hygiene. As for the radiographic exam, as you can see, it's a TBTT scan. We have an absence of periapical lesions, limited buccal plate. As for the position of the teeth, both of the teeth are positioned against the labial cortical plate. which means the extraction should be carried in a very smooth and atraumatic way. As for the case number 13, there is limited space at the apical and palatal portions of the tooth, okay, which even complicate the option of immediate implantation if we wanted to do it. Now I will talk about the surgical procedure step by step. First of all, I carried a necromatic extraction using a piezotome, the D1 for density of the bone, 18 milliliter per minute irrigation, and I used the LC2, LC2L, and R for the extraction. As you can see here, I managed to preserve the buccal plate, which is a crucial step. Then I started the bioactivation process of the graft. I mixed 0.5 milliliter of the product hyaluronic acid with 0.5 grams of mega-os. I mixed without saline till achieving a putty consistency, and I let it rest for 3 minutes. I managed to do the bone packing, so both sides. One of the sides contained hyaluronic acid plus mega-os, while the other side contained only mega-os. I did let's say a split mouse case. As for the punch harvesting, I went to the palate to harvest an epithelioconnective graft. But before going, I measured the dimension of the alveola, and I managed to choose correspondingly the size of the punch drill. Why I use the punch, epithelioconnective punch, instead of collagen membrane or PTFE membrane? Because I wanted to limit any bias that can affect my results, as for the interference of collagen membrane with bone or with the hyaluronic acid. And plus, we are in an aesthetic zone. Studies have shown that the use of epithelioconnective punch in the aesthetic zone in the socket preservation sealing can add and make it better in terms of gingiva and soft tissue presence. So as for the sutures, I made some sutures of 5-0 Glycolon sutures. 4 months later, we took a CBCT. As we can see, it's not any results, but we can see clearly in the site of tooth number 22, where we used only mega-os, we can see the consistency, let's say the radio opacity, you can say it's like bulky white. It's like we don't have any bone, de novo bone inside the space. While at the tooth number 13, which is with hyaluronic acid, we can see something like grayish. So such conclusion cannot be drawn from a CBCT scan. That's why I passed to a software using a semi-automatic segmentation. It's the ITK Snap. It's a superimposition software where I limited the site before and after and superimposed. If you can take a look at the figure number C, the grayish and outer box is the initial volume of the socket, and the pale pink is the post-operative 4 months. I managed to do some measures, and I had a 38% shrinkage rate for the control site, which means mega-os only. While at the test site, wait, let me move the box. Yes, we have a 26%. We can see the shape. You can imagine how the resorption has been made. And then I passed for a linear measure, since we know the majority of articles measures using millimeters and ruler and clinical thing. In my opinion, if it can be computerized, it's better for the results. I use a software called Cloud Compare. As you can see here from the color map, we have a mean resorption at the site of only mega-os 1.56, and a maximum resorption of 3.75 millimeters. That's something, it's clinically relevant. Every millimeter is really crucial in the aesthetic zone. While at the test site, we have a mean resorption of 0.75 and to a maximum of 2.9. Okay, during my implant placement, I managed also to harvest a bone for both sides. I used a stain called Giemsa Paragon, and at this stain, I aimed to measure the de novo bone formation using also a thresholding technique using the MHG software. I had like figure C, if you can see figure C, it's the de novo bone formation, the whitish area are the de novo bones. We have a percentage of 26.21% only of bone formation, while at the same site of mega os plus hyaluronic acid, we have a 59.61% of bone formation, which leads us to the fact that using hyaluronic acid in socket preservation, which is a simple result, simple technique, can lead us to ameliorate the quality and quantity of bone at 4 months post-op. Finally, what we know is that no straight conclusion can be drawn from a case report, that's for sure. Hyaluronic acid might enhance it, cannot, it might. We need further studies. Xenograft healing in terms of quantity and quality, larger population and different parameters should be addressed, and the idea of using solely xenograft should be left behind. We are in the era of biological adjuvants, even if it's PRF, even endogain, growth factors, or even hyaluronic acid. Anything to boost the healing of xenografts for the sake of the patient, of course. Finally, I will leave you with a quote of Sir Isaac Newton, who said, "What we know is a drop, what we don't know is an ocean." Thank you.
Those who are joining me live, we appreciate your support. And those who cannot, these presentations are 15 minutes long and will be available on our website, globalmegamind.com. Unlock your potential, test your mind. We are Megamind.